Good morning. Pleased to be here. I'm sorry I don't have a better topic for you, but at least it's a topic that we're all interested in. I've got some information that I hope will be useful for you. Please feel free, if you have a question during the presentation, to interject. If we are going to have questions and answers at the end, if you'd like to wait until then. The slide presentation that I'm going to go through is going to be available on the South Carolina Dental Association website, so if you need to refer to anything, it'll all be out there for you. I've started a couple of presentations with the question, how many of the people in this room believe that you have a good understanding of the Patient Protection and Affordable Care Act? By a show of hands. Good, excellent. They did a poll in the fall of 2010. The bill was actually passed in 2010, March of 2010. And they polled employers, and 60% of employers polled at that time said they had a pretty good understanding of the way this bill was going to work. Now, I don't know who these employers are because I'm in the industry, and it seems like we're being thrown loops every day, and it frankly couldn't be a whole lot more of a moving target or more confusing in my estimation. But yeah, 60% of employers polled back then said that they felt like they had a pretty good understanding. So hopefully at the end of the presentation, maybe some of us will be able to raise our hands and say that at least we have better understanding than we did when we started this meeting. Again, the name of the bill is the Patient Protection and Affordable Care Act. It's kind of an oxymoron, the Affordable Care Act. As things have unfolded and the taxes that are associated with this bill have become evident, it's not going to be more affordable for the people that currently have medical coverage. Really, the intent of the bill was to cover the people that aren't currently covered in the United States. So pick your number. We've heard numbers anywhere from 20 million to 37 million people in the United States don't have coverage currently. The intent of the bill in raising the taxes on the backs of the people that currently have medical coverage is to cover the people that don't. So make no mistake, for employers that currently offer coverage, the cost is going to go up, and it's going to go up rather dramatically. And we'll get into the taxes and the structure, everything that the bill has been showing us of late. It's going to increase medical costs for individuals, and it's going to increase insurance costs for the individuals out there that are under a sponsored plan. I think Mark's gone to get me some help. Okay, all right. We've all heard about the government shutdown, and again, that was tied to the Patient Protection and Affordable Care Act. Apparently the House presented the Senate a bill that didn't fund PPACA. The Senate refused that bill. Harry Reid came back and said, give us a clean bill. What's ironic is the initial bill that was presented to the Senate gave full funding for everything, less PPACA. So apparently Harry Reid's idea of a clean bill is a bill that gives him everything he wants. It's not good politically to say you're doing something that's going to raise costs. Unfortunately, I think they've shown a propensity to say what's popular over what's true. The reality is, and we'll get into the taxes as soon as I can get my presentation to populate here. I'll start showing you the taxes, and the taxes are directed to high-income folks. They're directed to everybody that currently has coverage. And just to give you a round number, what we're anticipating just for the cost of taxes that are going to come out in 2014, an additional $25 per covered individual, not employee, per covered individual per month. So if you're paying a $250 monthly premium, you just got a 10% increase as a result of your taxes. Billions and billions of dollars this bill is supposed to throw off in additional tax revenue. So what's happening in Washington? If we look at Washington, a couple words come to mind: acrimonious, uncompromising, divisive. Certainly they're not playing well with one another. I heard something the other day, you know, there's this pro football team in Washington, and they're talking about changing its name. We've all heard about that, right? Because the name is insensitive, it's callous, it's offensive. So going forward, I understand as of this weekend, they're going to change the name of the Washington Redskins, and they're going to start calling them the Redskins. Okay. Supreme Court ruling. The justices weighed a while back. Remember that we had that whole constitutionality challenge about whether or not this bill was constitutional? That whole challenge came up because opponents of the bill said that it was beyond Congress's authority to regulate commerce. They said you could not require somebody to buy a product. Now, proponents of the bill said, yes, you can. We require people to buy auto insurance. But those people are driving on public roads. How does health insurance affect national commerce? So they couldn't make that tie. So challenging the constitutionality of the law based on Congress's inability to regulate commerce, went to the Supreme Court. The reason Ms. Sotomayor has the Obamacare cheerleading outfit on, before she became a Supreme Court justice, she actually wrote opinions for the administration regarding how this bill was likely to unfold. So her vote was pretty well decided before it ever got to the Supreme Court. What the Supreme Court ended up ruling regarding the constitutionality was it was beyond Congress's authority to regulate commerce. They could not say that people had to buy medical insurance. But it's perfectly within Congress's authority to tax people for not buying health insurance. So that's how it was upheld on constitutionality grounds. That was Roberts' opinion. What happened in the early years in 2010 through 2012? I already told you the bill passed March 23rd of 2010. Well, since then, it's implemented women's preventive benefits. It's implemented a medical loss ratio reporting. This is interesting. It used to be that insurance was a risk business. If we made money on a dollar of premium, we kept it. If we lost, we had to eat into our reserves to make sure that we could continue. The medical loss ratio that was implemented with this law said for groups above 50 employees, the insurance company had to operate within a 15% margin. So 85% of the premium dollar had to go to medical care costs, 15% would go to administration. So here's how that works. If we get a dollar premium and we pay out 80 cents, we have to refund the additional 5 to the pool of employers that were in that group. If we pay out 85 cents on that dollar of premium, it's a wash. If we pay out 90 cents, we have to eat into our reserves to cover the deficit. So with this medical loss ratio, they've set up a risk business, an insurance business, where we can lose and we can tie, but we can no longer win. We have the good year, we don't get to keep it to offset the bad year. So going forward, it's going to be interesting to see how we're able to sustain the business without the ability to win in the good years. Now the loss ratio for the smaller groups, the groups under 50, is 80%. It's generally more expensive to administer a smaller group, a 2 to 50 group, than it is an over 50 group. Likely mandated changes for second-year summaries of benefits and coverage. Last year, fall of the year, we issued something called Summaries and Benefits and Coverage. This is a required benefit description that you have to release to your employees that are participating in your plan. We have to revise those this year. There's a couple things that they've added to it. So you'll be getting those out shortly. And the Patient-Centered Outcome Research Institute fees. The administration says that they want to identify best practices, so we're now having to pay a fee out of every insurance dollar to cover government research to make sure that best practices are being administered by the medical community. Challenges in 2013, obviously a dramatic change to each market. By a show of hands, are there any practices in here that have more than 50 employees? Okay, that's kind of, oh there is? Okay. All right, we'll speak briefly about the 50 plus implications, but for the most part we're dealing with employers of 2 to 50 employees. I already mentioned the MLR, beginning with the anniversary date in 2014, and this would be a good time to cover this. We moved the anniversary date up from January 1st to December 1st. The board made a very good decision there because what we're able to do by retaining a 2013 renewal, we can buy 11 months into 2014 on the current rating and benefit platform. If we renewed on January 1st, we'd be subject to new regulations and you'd have an entirely different rating. It would have been a lot higher had we renewed as normal on January 1st. So credit to the board for moving the anniversary date up 1 month. The other nice thing is with the exchanges and everything rolling out, obviously it's been a bit of a, I'll quote one of the sponsors of the bill, Max Balkas said, it's a train wreck. With another 11 months behind it, hopefully that as an option will be a better option for you as they get the kinks worked out. Massive infrastructure changes. There doesn't seem to be a lot of regard for how much money is being spent in the industry to implement all these changes, but I can tell you that the resources that have been devoted to this have been huge, and those include communications, preparing the SBCs, the resources. We've had to hire additional staff to monitor that we're in compliance because there's huge penalties for non-compliance. They've given us an extremely short implementation time frame. A lot of the rules come out last minute and we're expected to jump to and make sure everybody knows about them with a couple weeks notice. And there's still a number of final and proposed rules that we're waiting. Going back to what we talked about earlier about the taxes, these are some of the things that we're going to get hit by. Now, If we're looking for an Affordable Care Act, something that's going to make the actual delivery of medical care more affordable to those who need it, we've got a medical device tax. So if somebody needs a CPAP machine, there's now a 2.3% tax paid by the manufacturer on that machine. And you're all business people. Any cost that you have to pay shows up in the cost of your services. So putting a 2.3% tax on a manufacturer of medical devices isn't going to make it more affordable for the people that need it. There's going to be a 0.9% Medicare tax increase. So it's going to go from 2.9 to 3.8%. And oddly, the next number up there is a 3.8% investment tax credit, or excuse me, investment tax on income for those earning more than $200,000 as an individual and more than $250,000 for a joint filer. This has nothing to do with medical care. If you're an earner of more than $200,000 with investment income, you're looking at a 3.8% additional tax on your investment income. $250,000 for joint filers. They're going to increase Medicaid primary care physician payments to match Medicare over the next 2 years. This is another tax on higher earners, health flexible spending accounts. They used to have higher limits. Now they're limiting that to $2,500 a year. Well, who takes advantage of health savings, medical spending accounts? It's the people out there that understand the benefits of putting away money tax-free to pay for obligations. So by limiting this, people that were putting away more for predictable medical expenses are going to have to pay for the additional expenses above the $2,500 with post-tax earnings. And the Children's Health Insurance Program is going to be extended through 2015. So those are the 2013 provisions. In this timeline, key dates that we had, I'll just really refer you down to the bottom there. The July 31st, we had to start paying the patient-centered medical outcome research fees. We had to issue the summary of benefits and coverages. And initially, they wanted us to release the exchange notifications on March 1st. They delayed that until October 1st. So you all got some publications from Mark about where to go on the HHS websites and find out how to pull the information, talk about whether or not your plan met the minimum value standards. But those notices initially had to be released on October 1st, and then they came back and said, well, there's no penalties or fees if you don't do it. So if you didn't do it, there's no negative consequences. Again, we'll go back to Affordable Care Act, the dollar fee that we just talked about on the Patient-Centered Outcome Research Institute fees, risk adjustment fee, that's going to be $1 per member per year. Reinsurance fee, this one was going to kick into effect on 1/1/2014. They're going to charge $5.25 for every covered member, $63 a year for a reinsurance fee. And what this is designed to do is mitigate the losses of carriers that participate in the exchange. So if a carrier on the exchange has a disproportionate share of unhealthy, sick people and really gets tagged by their exchange participation, this money is designed to make them whole for their participation. This would be a good time to tell you, too, that on the exchanges, there were only 4 carriers that applied in South Carolina. So there's going to be slightly more than 50 plans available on the exchange to the people that want them after 1/1/14. And there's a bronze, silver, and a gold, no platinum plans out there. But this is going to be a big fee. The insurer fee, 2.3% of premium to operate in the insurance industry. Exchange fees, 3.5% of premium. And a Cadillac tax, this one's interesting. It doesn't go into effect until 2018, but there are a lot of folks contesting it now. What that says is, in 2018, if your premium for an individual contract exceeds $10,200, you're going to be charged 40% on the excess above the $10,200. So bear in mind, we've got all these new taxes inflating premium. We have medical inflation affecting premium. So 4 years down the road, $10,200 isn't going to be as rare as it is today. So it's almost setting us up for a lot of people paying a Cadillac tax. Now, if you look at rich benefits, benefits that are typically very expensive, you think about 2 groups. You probably think about executive plans, you think about union plans. So the biggest opposition that they've heard to the Cadillac tax has been among the unions who realize that they're the ones that are going to get hit by this. So this is one that we may see pulled off the table before it actually goes into effect.
George,
yes?
has anybody gone through and just added up, made a total of what the taxes are?
I'm glad you asked that question. The best we can figure In 2014, again, we're adding $25 per employee per month to the cost of coverage just to cover these taxes. And we're not sure that's going to be adequate. We'll have to wait until the end of the year to figure out if it was enough. That's a good question. Yeah. And again, I'll go back to the point. This is not affordable for the people that currently have coverage. It's designed to bring coverage to those that don't already have it. So again, going back to that 37 million number that we heard about, this is really what this bill is designed to protect, is those 37 million. The gentleman asked, what's the money being used for? Most of it's supposed to be allocated toward better patient care, or, I'll give you the Outcome Research Institute fees, and a lot of it's designed because they don't know what the impact is of sending all these people to the exchange. If the premiums that the carriers are charging on the exchanges are inadequate to cover the medical expenses, then they're going to have money to either make those carriers whole or see the whole exchange model collapse. Well, the administration wants to see all 37 million people that aren't currently covered with coverage. Well, the estimate is that 7 million people that are currently without coverage will be on the exchanges. So 7 million out of 37 million, or pick your number. Well, when you look at that 7 million, there's an awful lot of people that are covered under high-risk pools within a state. South Carolina has what we call the South Carolina Health Insurance Pool. You applied to 3 carriers, they all refused you, because the time to buy insurance is when you're well. Now, some people are they have some genetic condition and they weren't able to buy coverage before that was identified, or they got sick and then they decided they wanted the coverage. Those people that are in those high-risk pools now, as of January 1st, will go over to the exchange. So you're covered from day one for whatever you have. So when you look at that covered population, the chance for what we call in insurance adverse selection, instead of getting a good representation of healthy and unhealthy, it's going to be heavily weighted toward the unhealthy. So we've all heard about the employer mandate, right? There's been a lot of talk about employers having to pay for the population that they employ that isn't covered. We've all heard the debates about how many employers are going to drop employees from 30 or more hours down to 29 so they don't have to consider them in the covered population. Well, for 50 or more employees, there are penalties that were supposed to go into effect on January 1 of 2014. Those have now been delayed until January 1 of 2015 because apparently there's a lot of congressional seats that are up for re-election and they didn't think this would be very popular. So that's been pushed back to January 1, 2015. So bottom line is, if you employ more than 50, you're not going to have to worry about the employer mandate penalties for people that you don't have covered until 1/1/2015. At that time, if you have an employee who is eligible for your coverage and refuses it, and your plan doesn't meet minimum value standards and isn't deemed affordable according to the rules, then you'll be charged $2,000 for every employee that goes to the exchange and gets a subsidy. Now, if the employee goes to the exchange and is ineligible for a subsidy, you don't have a penalty if you're a 50-plus employer. So what 50-plus employers need to do is they need to make sure that they offer a plan to everybody that meets minimum value standards, those metallic plans we heard about, the bronze, silver, gold, and platinum. As long as it meets minimum value standards and it's affordable, which means the employee doesn't have to pay more than 9.5% of their W-2 wages toward the cost of coverage, and that's toward the cost of single coverage. So as long as you make sure that the coverage is affordable for your employees and meets minimum value standards, that employee is ineligible to get a subsidy exchange, and you're not going to have to face the penalty. Blue Cross, obviously, we're more than 50 employees. What we've done, we've bracketed, we made sure, of course, that all our plans were minimum value standards, by the government standards. Then what we did, we bracketed our employees' contributions. So if we had an employee that made between $18,000 and $20,000, we multiplied $17,999 times 9.5, divided that by how many pay periods we had. That was that employee's contribution. So we're getting less from the employees out there at the lower earnings, and we're getting more from the employees in the higher earnings. Basically, it's a wash, and then we don't have to pay the penalties because we don't have any employees that are exchange eligible. Okay. So I just gave you a lot of information that benefits a couple of people in the room, but most of the 2 to 50, they're not going to have to comply with the employer mandate penalties. So nobody else other than the 50-plus employers need to be concerned about that. 2013 ACA provisions. There's a provision out there that's going to require W-2 reporting for the total cost of coverage for groups that employ more than 250. Again, employer exchange notices to the employees stating that the plans meet minimum value or do not. And Mark has posted out on the website, right, Mark? The minimum value standards for the plans. So if you want to find out if one of the plans that you participate in with the dental association meets minimum value standards, you go out to the SCDA website and it'll tell you out there. They're requiring financial disclosures of relationships among health entities. So if a doctor's practice has been bought by a hospital or a doctor has an interest in an imaging facility, that has to be disclosed to the patients. And they're trying to expand Medicare drug coverage to make that more friendly for the people in Medicare. And again, the big thing is that they're rolling out the exchanges effective 1/1/2014. And again, that's what Max Balkus, one of the sponsors of the bill, said was coming out like a train wreck. He didn't feel like Kathy Sebelius was doing what she should to make sure that that was going to be a streamlined process. I will tell you that the exchanges opened up on 1/1 or 10/1, and since then, Blue Cross, who's the dominant carrier in the state, we have 86 applications for exchange coverage since 10/1. So it doesn't speak to a glaring problem of people just chomping at the bit to go out there and buy coverage on exchanges. The government put in an individual mandate, and again, this was going back to the Supreme Court ruling I told you about earlier. So what they're requiring employees to do, or excuse me, individuals, is to go out and buy coverage. Because the idea is that if everybody's covered, then you're spreading the risk out. You've got healthy people, you've got unhealthy people, and having everybody in the pool is better than having maybe the more sickly in the pool. So in an effort to get people to buy coverage, they figured that they were going to have a penalty to prevent people from waiving coverage. So given the fact they want everybody to go out on the exchange, okay, let's just work through a scenario. Let's say that your single coverage costs $250 a month, and you as the employer pay 50% of that $250. So the total annual cost of coverage is $3,000. You pay $1,500, the employee pays $1,500. The $1,500 the employee pays probably comes out of pre-tax earnings. So bottom line, it's probably costing the employee $1,100 or $1,200 in take-home pay a year. So your employee, or some employee out there, who is young, healthy, bulletproof, and immortal, 18 years old, cares more about a little bit of beer money on Friday night than he does about medical insurance, now has the choice of either buying your coverage at $1,100 a year or paying a $95 penalty for not buying it. So if he's waiving it for $1,100, why would he buy it in lieu of paying a $95 penalty? When Commissioner Farmer came and spoke with us the other day, somebody raised the question, now that we have this mandate out there and everybody in 2014 is expected to have medical coverage, what happens when that 18-year-old hurts himself and shows up at the emergency room at 3 o'clock in the morning? Business as usual. So this penalty is $95 or 1% of your family income, whichever is greater, in 2014. It raises to $325 in 2015, and it goes to $695 in 2016. I would tell you that this is not a penalty. Until the penalty actually exceeds the cost of coverage, you're going to end up right where you were. You're not going to have people rushing out and buying the coverage that we've supposedly mandated. Good question. The lady in the back asked, how is the penalty assessed? When you do your 2014 taxes, and you've got your W-2 statement, in your tax reporting, you're going to have to declare whether or not you had coverage. And if you didn't, you have to pay the $95. And if you're not getting a refund, are they going to chase you down for $95? I mean, how are they going to collect that? Anybody that's been following politics in South Carolina, we know that Nikki Haley's not a big fan of the PPACA Act. So we're participating in the federally facilitated exchange. And that means that the feds came in here, they invited carriers to participate and offer the plans that were required. And again, we have 4 carriers, slightly more than 50 plans meeting bronze, silver, and gold standards. There's a catastrophic plan that's available, but it's only available to people under 30 years old. So the carriers in South Carolina, there's a co-op that was government funded out of Charleston that's offering coverage on the exchange. There's Coventry, there's Blue Choice, which is a Blue Cross and Blue Shield subsidiary, and there's Blue Cross. So those are the 4 options that you have in South Carolina. Interesting, when employees are considering the exchange products out there, whether it's Blue Cross or one of the other carriers I mentioned, by offering the metallic standards that the carriers have to meet, the feds have basically commoditized insurance. So if you're buying a bronze plan from Blue Cross or from Blue Choice or from Coventry or from the co-op, people are going to be naturally inclined to think that a bronze plan is a bronze plan. There's not going to be any differentiation. So They're not hiring agents to go out there and explain the different merits of the various carriers. So since it's commoditized and people are basically shopping from their home computer, the low number on the page is probably going to win the day, because they're going to think that a bronze plan is a bronze plan regardless of who they buy it from. So since every carrier out there was chasing the lowest premium that they could possibly offer, we went back to all the providers that we had, the doctors and the hospitals in South Carolina, and we asked them if they could do any better on a more restrictive network of providers of doctors and hospitals than they're doing for us currently with our PPO plan. So what we were able to do was we were able to leverage Medicare allowances for the reimbursement on the exchange products. But for that, there's an awful lot of hospitals and doctors that don't want to accept that, and I can certainly understand that. So here in Columbia, we've got 4 hospitals that people consider Columbia hospitals. We've got Richland, Providence, Baptist, and Lexington, because Lexington is basically a bedroom community of Columbia. So before, all 4 of those hospitals were in the Blue Cross network. If you went to one of those hospitals, you got in-network benefits. Well, under the exchange product, we only have 1 hospital in Columbia and a much more limited network of doctors. So the delivery of medical care within the exchange product isn't going to be at all like what you're sponsoring on the medical plan that you have as an employer. So it's important that everybody recognizes that. The state did a very good job, the state newspaper, of exposing that, I think in this past weekend's newspaper. So good article about that. And here's the other kicker. Patient Protection Act that the state of South Carolina passed a number of years ago said that if you're offering a PPO plan, a network, non-network plan in South Carolina, or if you're offering any plan in South Carolina, you had to have an on-network option. Well, the feds supersede the state. So on the exchange product, we're not obligated to cover out-of-network benefits. So if somebody goes to Lexington, they're going to find themselves out of network and there's no benefits payable at all. So it's important, you know, as employers consider their exchange options, that they realize the differences between what they've got and what they would be getting out on the exchange. If there's an emergency situation where it's really not you selecting where you're going, the ambulance is going to bring you to the first place that can offer you care, there are provisions out there that cover that care. But for the most part, if you're making a decision about where you're going to get care, you can find yourself out of network and completely unreimbursed. Beginning January 1 of 2014, groups that renew after 1/1 are going to have to meet the metallic standards. And bronze plan is a 60% value plan, silver is 70, gold is 80, and platinum is 90. There are no platinum plans, as I understand it, out on the exchange. So people that would be out there looking for those plans would not find them on the exchange. But Blue Cross is going to be offering the metallic plans on a group basis beginning 1/1/2014. And when I say the 60% value, the reason those plans aren't going to look the same is what the feds require is an actuarial calculation where if a normal person has $6,000 in medical care in a year, if that's the average for South Carolina, a bronze plan has to reimburse 60% of that $6,000 or $3,600. The additional $2,400 can be patient liability. So the reason no plans are going to look alike is if you're trying to assign $2,400 in liability to a patient under a bronze plan, you can have a higher deductible, you can have a lower coinsurance. There's a lot of different ways to squeeze the balloon to make sure that that employee has $2,400. So when you go out on the exchange, it's not like the Coventry plan is going to look like the Blue Cross plan as far as the allocation of costs between deductible and coinsurance. So every plan now must meet essential health benefits. This is interesting because the essential health benefits are things like hospitalization, drug benefits, all the things that we covered already. So I don't know whether they were concerned about mini-med plans or voluntary plans from AFLAC and things like that, not meeting the standard for full coverage. But all the things, there's 10 items, and I'll show you those in a minute, that are required under essential health benefits. Your plans currently have all those. Going forward, claims experience can't be a rating factor in renewing a group, in other words, in changing premiums. So everybody that's in the small employer group, if you have the same characteristics as this group over here, and let's say this group over here has terminal cancer, you're still going to pay the same amount. There's no differentiation anymore in underwriting premiums. So everybody in the pool is going to pay the same amount if they have the same characteristics. Now, the only things that we can differentiate on are geographic areas. So we've got certain areas in South Carolina that are more expensive for care delivery than others. So we can differentiate premiums based on geographic areas, age, and tobacco rating factors. You notice they didn't say smoking, because there's a lot of ways to use tobacco. So we can differentiate rating based on tobacco use. We're going to eliminate the lifetime caps. Used to be that we had $2 million cap on care. Now with the 50% discount at the doctor and hospital community, you had to have $4 million in care delivered for us to pay $2 million. Well, now we can't have lifetime caps. So we basically have unlimited care. And this really never came into the play. I mean, the 30 years I've been with Blue Cross, I never see us pay $2 million out on anybody, even organ transplants, things that you would consider very expensive care. And then we had a burn victim. And she went down to Augusta and she lived. And her claim was $3 million. That was the first one I'd seen. But the wild card now in the equation is the Patient Protection and Affordable Care Act is requiring carriers now to cover investigational and experimental procedures. And it loosely interprets those. It's not like they have to be vetted by the AMA or the FDA. If a person's in treatment for something investigational or experimental, we have to cover it. Now we have to cover it with no lifetime limit. A counterpart of mine was up in North Carolina, and he heard about a situation recently. The wild card now is specialty drugs. You're in the business, so you probably are aware of this. They've got drugs directed to very unusual and specific conditions. So they're not mass producing it because the condition is so rare. So the cost of the drug for the few people that they've developed the drug for and that they're actually selling it to is astronomical. My counterpart up in North Carolina told me about a situation where they've got $23 million in payments on a single claimant for a drug that costs $30,000 a teaspoon. So that's, I think, where the elimination of the lifetime limits is really going to be striking. Coming forward, they're going to limit annual deductibles. Now, you might recall we talked a little while ago about the Cadillac tax. A lot of employers, to mitigate their premium cost, have gone with higher deductibles. You raise the employee liability, you lower your premium cost. Well, by limiting annual deductibles and placing caps on those, the cost of premiums are going to go up, which is going to make it more likely, as medical costs continue to increase, that people are going to be tagged with that Cadillac tax in 2018. So it's going to be real interesting to see the way that plays out. The employment waiting period for coverage cannot exceed 90 days as of 1/1/2014. So if you've got a probationary period, if an employee comes to work for you and says, listen, as soon as I'm eligible, I want to be on your coverage, if they've got more than 90 days satisfied as of December 31st, 2014, you need to put them on 1/1/2014. Excuse me, they have more than 90 days satisfied as of 1/1/2014, you need to put them on. If they're serving a probationary period that would complete less than 90 days in 2014, you can wait to put them on. But the bottom line is nobody can serve more than 90 days toward coverage as of 1/1/2014. So what we're recommending, we typically go first of the month effective date. So what we're suggesting is do a 60-day probationary period and put them on the first of the month following 60 days of employment. And that way you'll always be within the 90. The gentleman asked a very good question. He asked if they have to go to the exchange if they don't want our plan. The gentleman asked the question, if you have the unhealthy group and the healthy group, would the rates go up? Yes, they're going to be average and you're going to have to meet in the middle. So if you happen to have a very, very healthy group, you're going to be lifted, your premiums are going to be increased by the fact that you're subsidizing the one that had the catastrophic claim. On the other hand, you could find yourself in the catastrophic category and you'd really like this idea because it would bring you back down to an average. Whenever you have an employee come in that you would normally cover, they meet the criteria for hours of employment. Whenever you have an employee come in, if they don't enroll in your coverage, get them to sign a refusal. So on the enrollment application that you would normally complete for coverage, there's a block in there that says refuse coverage. Get them to date and sign that, because if they come back later and say they were never offered the coverage and it's your word against theirs, chances are the Department of Labor is going to side with them and you're going to be self-insured on whatever condition they've developed that they want coverage for. So document every employee when they come to work, if they want the coverage, if they don't want the coverage, make sure that you keep the applications on file. Yes, ma'am.
Suppose we've hired somebody as a part-time person under the agreement they wouldn't have insurance.
Right.
Is there an hourly, if they work over a certain amount on average,
Right.
do we have to offer insurance?
You're actually in great shape because the standard for coverage with the Dental Association is 24 hours. Typically with Blue Cross, you have to work 30 or more hours a week, 48 weeks or more a year. So the Dental Association's criteria for coverage is 24 hours, which is lower than ours. But since the feds require 30, If you have somebody that's working fewer than 24, you needn't do anything.
Suppose it's all over the place, so that it might have a job.
Their ruling on that said that you can look at a period of time, whether you review it on a quarterly basis or an annual basis, to determine whether or not that employee would be considered full-time over a longer period. So,
But
you're,
probably should have that waiver.
yes, oh, absolutely. If they're not on your coverage, definitely get the waiver. But if you need to find out whether or not they would have been eligible for your benefits, the feds again use the 30-hour standard. You could use the 24 with the Dental Association. Yes?
I'm a little confused about if you have an employee who works 24 or more but less than 30,
Right.
and you're on the Dental Association plan,
Right.
you have to offer coverage to that employee?
Yeah, they're part of the eligible class. Yes. And if they don't take it again, get the refusal. Okay, individual coverage subsidies. We've heard a lot about how the government's going to make cost of coverage more affordable for the people that don't currently have it. Again, I would tell you that I'm anticipating that the people that don't currently have it, don't currently want it, aren't going to take it. But in order to make it more attractive, for qualified individuals, if you earn between 100 and 400% of the federal poverty level, you can qualify for a subsidy on the exchange. So what you have to do is you have to go out there, you have to fill out a pretty extensive application, declare your income, and then apply for a federal subsidy. And that subsidy comes back directly from the feds to the insurance carrier, and then the employee is responsible for paying their portion, or the employee can file for reimbursement at the end of the year. There's a couple of ways to handle it. I think most of them will probably get the money up front, the cost sharing with the employee or the individual for the insurance company. There's also a lowering of cost sharing for deductibles and co-insurance for people below 250% of the federal poverty level. Okay? I'll go back to this point, and again, this only affects the 50-plus employers. Individuals and dependents who have been offered coverage through an employer that meets an affordability and minimum value test are not eligible to purchase coverage through an exchange or get a subsidy. So if they have your coverage as a 50-plus employer, the exchange really has no benefit for them. And again, the premium subsidy will come in the form of a refundable and advanceable tax credit paid directly to the individual's insurer. The other option is they can pay the full amount and get it back at the end of the year. And it's based on the premium for the silver plan, the second lowest plan in the area where the individual is eligible to purchase coverage. You know, an awful lot's been made about the exchanges and how many people it's going to benefit. This was interesting. The Congressional Budget Office, which I would say is probably leaning a little bit toward numbers that favor PPACA, said 57% of people in the exchanges will get tax subsidies, 43% will not. So if they meet an income threshold that doesn't qualify for them for an exchange subsidy, they're just basically buying coverage on the exchange and not getting any federal assistance for doing so. This was interesting too. The CBO made clear that the average premiums would be 27 to 30% higher because the law demands greater insurance coverage. Well, these bills have thrown an awful lot of preventive care and other provisions in that are actually increasing the cost of care. Because when we're having to cover more things, unlimited lifetime maximums, that type of thing, again, the cost of coverage goes up. So I attended a webinar recently. A friend of mine invited me to a competitor's webinar, and they said individual premiums are probably going to go up 132%, not this number, but 132%. So an individual buying coverage, now that there's no pre-existing, there's no health underwriting, bring us everybody, we'll take them all. A premium that used to be $100 is now going to be $232. 132% increase. And this wasn't Blue Cross. This was one of our major competitors. They also said that large group costs were probably going to go up a minimum of 20%, and 2 to 50 costs were going to go up by more than 25%. So it's wonderful that when you look at the renewal that you got this past, well, you just recently received it, 9.4% increase, and it encompassed all these taxes that we're looking at for 2014. So I sit around the negotiating table with Mark and Phil, Lee, and your board, and they do a very good job on your behalf because technically you could almost support a 9.4% increase based strictly on the new taxes, let alone the cost of medical cost increase. So you've got a board that represents you very well. Why would a person continue to buy coverage through their employer versus going to the exchange? Well, on the group market value proposition, typically the benefits are going to be richer. Again, you have out-of-network care. You have bigger networks. Employer reduces exposure premium cost to the employee. You're offering something to the employee for them buying coverage. If it's a minimum of 50%, which is what our contract requires, that's a pretty good offset to the cost. And they can pay their 50% with pre-tax dollars in most cases. Burden of payments and product selection taken care of by your employer. You don't have to go out there and navigate the market. And why would you offer health insurance? Well, it's a differentiator to attract and retain talent. I came to the conclusion a long time ago that nobody buys my product because they have too much money laying around. You know, if you weren't attracting and retaining better employees, if you weren't trying to hire this person that person over there wants just as badly as you do, you wouldn't offer it. And I couldn't blame you. Individual market proposition. Some employers are talking about increasing employees' salaries due to lack of group-sponsored coverage. That is an argument that has a little bit of a problem. If you just increase their cost, let's go back to the example we used earlier. You paid the $125 that you were paying toward the cost of coverage. Now you just increased their salary by $125. Well, you're going to have to pay the matching taxes on that $125. So it's costing you money. Your employee is going to have to pay the matching taxes and their normal taxes on that boost in salary. That salary is not going to come to them in pre-tax dollars. So the shrinkage that you're going to realize by inflating their salary by the amount that you used to contribute to the cost of medical care isn't going to make them whole going to the exchange. And a lot of employers haven't gotten that yet. Benefits are portable and not tied to a specific employer. I guess that's a nice thing from a continuity standpoint. If you've got an employee out there, or an individual out there that jumps around employment a lot, they never have to worry about resecuring coverage when they leave one employer and go to another. There's a much broader range of potential options to select from, but again, if you were to poll employees, they'd probably be confused as the devil trying to go through all the options that are out there on the exchange. And in this situation, if you offer exchange, then health insurance is not differentiated for targeted markets. So you wouldn't be differentiating yourself from any other employer out there in not offering it. A couple more points, and I won't cover all this because it's a little bit redundant with the prior slide, but a healthy workforce is directly linked to productivity. I think that's one that really has a lot of truth to it. Again, you can attract the best workers and remain competitive. And the federal government supports employer-sponsored coverage through the tax code by recognizing firms' insurance premiums as a business cost. So you get to deduct those. So there's an awful lot of ways that you're actually expanding the benefit to the employee by offering a sponsored plan. And the employee benefits, again, the cost of coverage makes it much more affordable for the employees. They have the ease of purchasing through their workplace, payroll deduction, that type of thing is easier for the employees. Why buy from the SCDA? You know, it was interesting. Before this meeting started, a very nice lady came up to Mark, and she gave him some kudos for how quickly he responds to her questions. And I can tell you that if Mark gets a question from one of you members, it's on my desk within minutes. So again, they negotiate prices for coverage that best fits their need. Again, going back to the board's negotiations on your behalf. Designing benefit plans, I think they found competitive benefit plans for the marketplace. They explain the coordination issues of public and private benefits to individuals and employers. They solve the problems once coverage is in place. And I like this last bullet point. The record clearly indicates that government bureaucrats are ill-equipped to provide the personal service, timely objective information, guidance, and accountability that professionally trained and licensed SCDA staff delivers on a daily basis. Have you ever had a relative call Medicare? Has it been a wonderful experience? I mean, half the time you feel like you're explaining Medicare to the Medicare person. So that's really what the exchanges are going to be like. So I do have to give, again, Lee said that I work with 11 associations. The staff that we have here at the SCDA is among the best. Yes, ma'am. The lady up front asked if you don't change your coverage, everything status quo as of 12/1/2013. With the first anniversary date in 2014, we're going to have to go to the new requirements for the metallic plans. So there's going to be a bit of a shakeup in the plans that we offer. In other words, instead of having design plans that were orchestrated by the Dental Association and Blue Cross, we're going to have to go to metallic standard plans. So there's going to be a bit of a difference there. The other things.
But only if you haven't had good insurance to begin with.
No, ma'am. Unfortunately, this is going to affect everybody.
Beginning. I asked Mark that. He said no.
Well, beginning 12/1/2014, we are going to have to go to the metallic standards. The government requires that. The other thing that's going to be a bit problematic for us is we're going to have to go to a rating platform that compresses the rates. I don't know if any of you have heard about this, but the difference between your most favorable rate, let's say a 19-year-old male, and your highest rate, which might be a 65-year-old male, the lowest rate can't be, or excuse me, the highest rate can't be more than 3 times the lowest rate. So we're right now, we might be working within a highest rate that's 200% of the lowest rate. Now we have to compress everything so that there's this 3-to-1 ratio. Now we can still have 10 different rating categories in there, but the feds are going to dictate that the worst rate can't be more than 3 times the best rate. So we're going to be operating within a much more narrow range of rating than we are currently, and that's going to be difficult. Yes, sir.
When does this start?
On the anniversary date, 12/1/14.
12/1/14.
And that's one of the reasons why we changed the anniversary date, so that we can enjoy the current platform for at least another 11 months into 2014.
So are you actually saying that if we're in that highest group for our premium, 2014 we can expect our premium to go down?
Well, again, that's a good question. Yeah, gentleman asked if we could expect the premium to go down. That would assume that the higher rating, the rate up that we have within the Dental Association, is currently higher than the average for the entire group. If the rate up is even lower than the average that we have within that entire pool of employees, then it could be neutral or it could potentially go up. But in likelihood, you might see that rate come down. Yeah. Any other questions about that?
Even with the add-on and the tax structure and everything?
It's possible. I really don't want to speculate on that because that's more the job of the actuaries and the underwriters. But all I can say at this point is it's possible, but I can't even begin to speculate on where it's going to come versus the rate up. Okay. 24. Yes.
That narrowing of the rate, is that based on those criteria that you're only allowed to change rates on? Like, will that be within an age category, it's 3% difference, or will that be across the board, regardless of geographic area or age?
Right. The lady was asking about how that stacks up with the geographic areas and all that. What we're going to do, we're actually going to formulate a rate table that's going to be based on the entirety of the Blue Cross business. So a 19-year-old would pay X for this particular bronze plan. Maybe a 20 to 22-year-old would pay X plus whatever. And there would be a rating table that would be defined. In other words, we would go into a specific group and say, you're going to be this. We're going to tally up every participant within the plan, and their rate off that table is what's going to dictate what that practice is going to have to pay for the members they have covered. Another interesting factor here is, it used to be I could offer a single and family rate. So if I had a wife and 2 children, and somebody else had a husband and 2 children, they would pay the same rate on the same plan if we were the same age. Well, now, each member of the family is assigned a different rate. So if I'm 55, and let's say my wife was 55, well, we pay the same premium, and because we'd be in the same geographic area, and assuming neither one of us used tobacco, we pay the same premium. Well, then the children, we'd have different premiums determining whether or not they were like adult children. You know, we have to cover children now until age 26, right? So the children would have different premiums. And just because we're both 55 and work for the same employer, and we both have family coverage with 2 children, we're not going to pay the same premium anymore. It's all going to be individually based. So that's really going to complicate things going forward. Yes, ma'am. The lady just asked the question. She had a husband older than her. How would the premium be calculated? It would be her premium at her age and his premium at his age. Those two would be added together to figure out what the employee spouse coverage total cost was. The lady was asking about the criteria for the dental association coverage and whether or not the employer has to contribute 50%. Now, the rule is that if you're sponsoring a medical plan, you have to pay 50% of the single cost of coverage, not the family portions, but at least for the employee, The minimum standard is that you have to pay 50% of the single cost of coverage to sponsor a medical plan through the SCDA.
Unless you're grandfathered in.
Right. Any practice that was there before July 1st, 2004, right, Mark? Could potentially be grandfathered and waive that exclusion. That's when we assumed the group from CCP, and we changed some of the standards for the new practices coming in.
I heard that was actually going up to 60% next.
Yeah, one of the laws does require that employers pay 60% of the cost of coverage. So, yeah, that will be a difference. Now, until they actually implement it, who knows? They've waived on so many other things, but yeah, that could be a possibility. Yes, ma'am?
Will that still apply to small employers even though you're not required to offer it all?
Well, good question. The lady was asking, does that still apply to small employers who don't have to sponsor coverage? The issue is, if you do sponsor coverage, you would have to contribute 60% of the single cost. If you don't offer coverage, then obviously no contribution is necessary. So yes, if you continue to sponsor a medical plan for your employees, when the feds change that standard, if they change that standard, you'd have to start contributing a minimum of 60% toward the cost of coverage. Okay, removal of pre-existing conditions. Another one. Going forward, if an employee comes to you and they've got a serious medical condition, we can't say that that's going to be excluded from coverage or that they're going to have to wait a certain period of time before they can be covered for that condition. When they come to work, we have to cover any pre-existing condition on the day they get there. Our president used an interesting analogy the other day. He was actually talking about the exchange product, but it's true here too. The person comes and gets coverage. The day before they're diagnosed, or the day before they come to work for you, they're diagnosed needing a heart transplant. We have to cover that from day one now. So, again, it's that whole theory about you can wait until you need it before you buy it, and you don't have to worry about whether or not your pre-existing condition is going to be addressed. Guaranteed issue and renewability. That's never been an issue for Blue Cross. We've never canceled a policy holder for anything other than non-payment of premium, but apparently some carriers see a drastically ill person cancel coverage. In my 30 years, I've never seen Blue do that. Removal of restricted annual limits on essential health benefits, we've already covered that. Again, no waiting period exceeding 90 days, we've covered that. Coverage of the essential benefits, no discrimination based on health status. We have to treat everybody equally. And again, new health insurer fees. These are the essential health benefits. I alluded to these earlier. You can see that all these things were already covered in the policy that you have with us now. Very basic stuff. But again, I think this was to iron out mini-med plans, very limited plans. If an employer tried to say that his Aflac cancer plan met these standards, or was it his coverage, he can't do that. It's got to cover all these things to be considered a program offering essential health benefits. Now going back to the opening where I asked how many people felt like they had a good understanding of healthcare, love this slide. Enid was finally ready to admit that compliance was a bit more complicated than she first thought. Okay. I know you've been very interactive, and I certainly appreciate that. We've asked a lot of questions during the meeting, but does anybody have any questions before we conclude? The lady was asking if there was a law that required that children be covered on the parents' plan. There's not a law to that effect. Now, if one of the employees or one of the parents has a court order requiring them to get coverage, I would think that that would dictate them having to go out there and find something on an individual market that would cover the children. But no, there's no law out there. There is the individual mandate penalty that says if you don't cover your dependents, there's a cost of not covering your dependents as well. But you can waive coverage on your dependents just like you can on yourself. But I would think that the court order would dictate that situation. The lady asked about when we were going to be changing the rating methodology to cover each individual covered gets a different premium. That actually is going to go into effect on December 1st of 2014. And that's why we moved the renewal up so we didn't have to deal with that for another 11 months into 2014.
I got one question.
Yes, sir.
Got in a little late, so if this has been answered, I apologize. But I've asked some of my friends who I respect, are you worried about this? And they go, no, not really. We got a letter from our CPA, and this is what he said to do. So tell me what is wrong with this statement. Basically, what I understand to this point is, and what you just said is, if we offer a plan through the SCDA, which we have right now, and we have an employee who wants to be on it, we need to cover right now 50% of what their single coverage is.
Right.
That's our obligation. All right, my friend tells me, no, what we do is we give them, let's just use this number, we give them $400 a month in their check, and they go get their own insurance through, maybe Obamacare is not the right word, maybe it's this term that you've got, let's just call it Obamacare while we can. Then they take that $400, they go online and they try to do all this stuff. And Cheryl and I were talking coming over here, we're going like, man, that's a no-brainer. Just give them $400 and let them get out in the pool and fight the sharks off and try to get the best deal, let them broker this stuff and all this kind of stuff. Is that a fair assessment of what we're looking at right now? Here's $400 or here's $500. You take it, put it in your little red wagon, and good luck. Is that kind of what we're looking at? Is that oversimplifying this from a dentist employer standpoint, or is it a lot more complicated than that?
Well, what we discussed a little bit was the coverage that you're going to get on the exchange isn't going to marry up with what you're getting as an employer-sponsored plan, because the networks are going to be different. You're not going to get out-of-network care, and the networks are going to be much more limited. So if you're concerned about access to providers, the exchange coverage isn't going to be as beefy as what you currently offer. To sponsor a medical plan, employers have to have within the dental association 50% of the full-time employees covered and make a 50% contribution toward the cost of care. So those are the standards that we have in place now. The gentleman correctly said that down the road there's a provision out there that's going to require employers to offer 60%. But I would think, from my perspective, if I were a business owner and I was currently sponsoring a medical plan, if I were thinking about myself and my family, I wouldn't want to find myself on the exchanges just because of the much more limited provider networks that you're going to have out there, and the chance that you are going to need care that's not available in network. So right now Blue Cross has 100% of the hospitals in South Carolina covered in our broad network that you participate in. We have 95% of the doctors, so you'd almost have to go on a hunt to find an out-of-network provider. It's going to be the opposite of that within the exchanges. So if you're concerned about having good access to medical providers and being able to attend the hospital, or go to the hospital you want to, the exchange probably isn't going to be your answer. The other thing too that we discussed is, let's say you're currently paying $400 per employee on the plan that you've got. Well, if you give that employee $400, and assuming that that's just a salary increase, they're going to have to pay their taxes out of that. So they're not getting that all available for benefits. In other words, if they lose an incremental portion of that to taxes and then only have the net to buy product with, is it really a wash for the employee?
But is that, are we okay legally from the Affordable Health Care Act to say do that? Are we?
Absolutely.
Are we fine?
Absolutely.
So really, you could look at this from an employer standpoint and really just, say do whatever you want to in Washington. This is a no-brainer for me.
Precisely, because in the 2 to 50 market, there's no obligation for an employer to sponsor a medical plan. Now, bear in mind, there was no obligation for you to sponsor a medical plan previously. Even before Obamacare, nobody in this room had to offer medical benefits to your employees. There was no law that said to do that. But again, going back to the slide that said, if you want to attract and retain employees, chances are a sponsored plan is going to get you better employees and allow you to retain those employees. But what you might find, and a lot of employers are considering that very option, have a defined contribution. I'm just going to pay this much per year, and I don't care where costs go. I'm going to give them this much money, and if they can find something, great. If not, they can supplement it with the difference. But I think what they're going to find is the employee experience on the exchange isn't going to be what it is in the employer-sponsored plan. And people buy insurance because they have something to lose. If you have nothing to lose, you don't buy insurance. If you don't care about who you owe money to, going back to the guy that doesn't buy coverage and goes to the emergency room, the young, healthy, bulletproof, and immortal type, he doesn't care about his credit rating. But if you have something to lose and you're truly concerned about the delivery of health care and getting well, I think you'll find yourself much better served on an employer-sponsored plan than you will on the exchange. The other thing too, going back to something we alluded to earlier, the premiums for this year on the exchange are artificially set. There's an anticipation of the population that's going to end up in the exchange. The initial estimates were that an awful lot of the 37 million uninsured in America were going to go to the exchange products. Even Health and Human Services now has lowered that optimistic number down to 7 million. Of the 7 million that are going to go there, anybody that's been refused coverage before for medical conditions that wants medical coverage is going to find their way to the exchange because we don't have pre-existing condition, we don't have health underwriting. So if you've been refused previously, the exchange is a godsend. Anybody that's on the South Carolina or high-risk pools for any given state are going to find their way to the exchanges as well. So I would contend that end of the year, you're going to find that disproportionately a very unhealthy segment of the population is going to be in the exchange, much more so than we've got within our employer pool with the SCDA. So ultimately, I think that the employer pool, the individual pool that you're going to see is going to be much better SCDA at the end of 2014 than the exchange pool. And all the exchange rates are going to be adjusted based on the claims experience that they're going to see within 2014. So it might look great today. I'd like to see what it's going to look like January 1 of 2015.
And the money that pays for the exchange pool and all these people who have no pre-existing conditions, all that is being paid for by who and how?
Well, the carriers that agreed to participate on the exchange are going to receive a premium for the coverage that they extend. So the carrier is going to be at risk. We were covering earlier that there's a reinsurance fee that the feds are going to be collecting from every covered individual that's part of the $25 per employee cost that we're having to add to the premium to pay the feds. But part of that, $5.25 per covered individual per month, is going to go toward mitigating any losses that carriers experience within the exchange. But the anticipation is it's probably going to be inadequate to cover the loss ratios that you're going to experience within the covered population in the exchange. The lady was asking about if you currently pay more than 50% toward the cost of your employees' care, their premiums, can you take that down to 50? Absolutely. Our contract simply says that you have to keep 50% of your eligible employees covered, and typically that's driven by how much you're contributing. So you want to make sure that if you have 4 employees, you've got 2 covered, and if you drop your contribution, would they remain covered? And the other thing is, you can take, as long as you maintain your participation, there's really no issue at all. The lady was asking about the 3-to-1 rate compression and covering each covered member based on a rate appropriate to them. That's going to be on the 2 to 50 business, employers between 2 and 50 employees, and it's going to be every carrier in the country that's offering medical coverage. Now, our rate might be different because of the network and the discounts that we have than another carrier. In other words, we're not all going to have the same rates, but we all have to work within those confines of the 3-to-1 rate compression and the metallic plans. Okay, the lady was asking if we could establish a cap at 50. It actually has to be 50% of the cost, the single cost, should be the employer contribution. Okay. Yes, sir.
Yeah, I was just curious, in other states that chose to participate with the government, are their rates going to be cheaper than South Carolina because we chose not to?
So you're asking about state-sponsored exchanges?
Right.
I wouldn't think so, because even if the state sponsored the exchange, they're still soliciting carriers to come in and offer the benefits against the metallic standards. So, for example, if California operated their own exchange, they're going to do the same thing the feds did in South Carolina. They're going to go out to carriers, they're going to ask them to offer plans of benefits and rates, and then they're going to select who they ultimately offer to the citizens of California. So there shouldn't really be any differential, I would think, in the methodology of how the rates are set.
Well, we should be getting more government money toward it.
No, that's another good question. The gentleman asked if they get more money, or if we get more money because we're in a federally facilitated exchange. The folks in California on the state-run exchange, it's really just a different administrator of the exchange. Those folks are going to be eligible for the same subsidies in the state-run exchange in California as our folks are in the federally facilitated exchange. Really no difference. Well, as an employer, it kind of depends on where you're in business. If it's important, if the people that you would look to hire have a high expectation of an employer-sponsored medical plan, and if you're unlikely to be able to fill your employment needs by not offering it, I would say sponsor the medical plan. If you're in an area where there's not a high expectation of employee or employer-sponsored medical benefits, then certainly weigh the cost to the benefit and decide if it's something you'd like to do. But again, I think employers offer our coverage because they're trying to attract and retain good employees, and the employees out there that have an expectation of medical coverage, they might work for an employer for a period of time, absent coverage, before they find some employer that would offer it. So you'd always be vulnerable to them going to work for somebody else that might sponsor medical benefits for them. What a lot of people don't realize is that typically the plan they're buying through their spouse isn't free to their spouse. Now, in your situation, it might be. She might work for an employer that pays for the cost of employee spouse coverage instead of just single coverage. But if her employer is like most employers, they're just paying a part of her cost of coverage, and then she's paying the difference between the cost of her single coverage and what her employer sponsors, plus the cost of adding you to her policy. So what I would suggest is it's probably always a good idea to look in and see, first of all, are the benefits that she's offered as good as the benefits you're offered? And is the incremental cost to her through her employer exceeding what you could buy single coverage for through the South Carolina Dental Association? So if you weigh all those things, you might find that you're better served coming off of her policy and going on to your own individual policy through the SCDA.
Well, how about if you're her employer? So how about if you are her employer?
Well, then she would be considered an employee among the eligible class, and she could either refuse or take the coverage as long as you maintain 50% of your eligible employees enrolled.
How about if the other employees decline?
Well, the rule of thumb in insurance is that you have to have an adequate spread of risk, and typically we have a 75% enrolled criteria. So if you had 4 employees, you'd have to cover 3 out of 4 in order to sponsor the plan or choose individual policies. But with the Dental Association, because the group that we assumed from CCP way back when allowed 50, we assumed the 50 as well. So 50 is really the floor.
And if you don't maintain that 50% level, then you lose your coverage as well?
Right, we have to have a minimum of 50% of the eligible employees. Yeah. I'm sorry, we got a lot of hands. I'll take it from the front to the back. Yes, sir.
If you're grandfathered in and then you decide to hire a new employee and offer them insurance, does that mess up your grandfathering?
Well, it would depend on the basis for your grandfathering. If your grandfathering was that you wanted to have a dental-only plan, and back before 2004, CCP allowed that, and we assumed that criteria, but we closed that class. We said to have a sustainable program, we have to have 50% of the eligible employees enrolled going forward. I would say that if you're a practice of 5 employees, including the dentist, and you've historically not sponsored a plan to your employees, so you got 4 people not covered and the dentist who is, if you hire a new employee and you offer that employee coverage, you're really going to have to offer it to everybody or be accused of discrimination. So anybody else in the same class would have to be offered the coverage that you offer to the new employee.
Right, but if you offer it to them and they refuse, does that still mess you up if the new employee does take it?
It would mess you up, I think, even if you offered it to them and they refused, because now you've opened an eligible class. Their refusal really is immaterial. You've offered coverage to another person. So I would suggest either keep it the way it is, where only the dentist is eligible, or open it up to everybody. Well, within the grandfathered population, we had some dentist-only practices. So they never extended the benefits to the staff. And by South Carolina insurance law, you're really not allowed to do that. A group plan has to be offered to the group. So you can't have a group of 1 person, right? So we closed that class, and we anticipated that over time, those dentists would retire or they'd sell their practice, and the new dentists would be subject to the criteria that we're looking for from everybody else. And slowly but surely, that grandfathered class has dwindled. So it probably won't be much longer before it's gone. The rule of insurance in the past had always been you could discriminate by class, but you can't discriminate within class. So if you had a certain contribution, let's leave dental for a minute and just go over to a traditional employer. So they cover all their management folks, and they contribute 75% of the cost for everybody in the management class, 50% for everybody in the hourly class. That was allowed previously. There are some rules pending in PPACA that would prevent that going forward. But for right now, until they actually weigh in and finalize the discrimination rules, you can discriminate by class but not within class. Treat everybody within a class the same, and you're fine for the time being. Right the lady was asking, again, if you pay 100% on one class and 50% on another, is that okay? As long as everybody within a given class is the same. If you have somebody in one class that could also be in the other class, you could have problems with the Department of Labor. For the time being, until again they weigh on the discrimination rulings, for the time being, a dentist can potentially have retiree benefits post his employment with the practice. So if he sells the practice and retires and meets the criteria, he or she could potentially continue coverage past employment. Our plan is an employer plan, and most plans don't allow for retiree coverage. When you quit your employment, you're no longer covered. But the Dental Association, again, predating Blue Cross coming onto the coverage, had a retiree benefit there, and it also had a surviving spouse benefit. Now, we don't know if the feds are going to allow that to continue indefinitely. There are some anticipated rules that are coming down regarding discrimination, and clearly this is discrimination because it's available only to the dentist. So if they rule that this is disallowed, then that's going to go away, and really the benefit to the grandfathered class would be minimal after that. Excellent question. The lady was asking about, there's actually two different exchanges out there. And she was asking about the rate difference between Blue Cross rates and the small group rates that you might find on the exchange. There's something out there called the shop exchange. Blue Cross is participating in that as well. And we've got two plans out there. I think there's a bronze and a silver. I believe those are the only two that we offer. But as far as the rating on that goes, you would actually have to apply your census, and we'd have to rate based on the census because each person's going to get a different rate there too. In other words, it's not a single family employee, spouse, employee, child rate that's specific to a given practice. We'd have to have a census that included every covered member, whether it's an employee, a spouse, or a child, in order to give you a rate to figure out where you would be on the shop exchange. Okay?
It could be more.
It could be more. Yeah, right. And there's some anticipation that there's going to be some adverse selection there, just like there is in the individual market, and the rates would be higher. Right now, you're in a pool of employers, and the people that you have working for you are coming to work every day. That's typically a healthier population that you might find in the individual market, or maybe somebody's on disability, and they're paying their premiums out of that. So I would suggest that the pool that you're in right now through the SCDA is going to be much, much better going forward than the shop exchange as well. Lady was asking about which hospital is in the exchange now and whether or not there'll be more going forward in 2014. Certainly, if more wanted to participate in the Medicare pricing that we're giving the hospitals, we'd be open to receiving them. But right now, having been presented this, the only one in the network, I believe it's Palmetto Baptist, is the Columbia Hospital. Please don't hold me to that. It's all out there on the website. But again, I'm not marketing the exchange product, so I'm not that familiar with it. But I do know that we only have the one hospital, and I believe it's Palmetto Baptist. So the dilemma comes in is, if your physician doesn't have admitting privileges at that hospital, your physician might still be in the Blue Cross network, but maybe they don't admit to that hospital. So to your point, that would be a dilemma. Now, if somebody did apply, if one of these hospitals said, we can't forego the Blue Cross membership that's on the exchange, and we now want to come back to the table and offer you the Medicare pricing that you negotiated with this other hospital, we would certainly take that hospital. But I think that they're going to have to see what kind of business they lose for not participating before they'll make any decisions about coming back to the table. Excellent question. The lady was mentioning that we're renewing effective December 1st so that we can have 11 months into 2014 on the new platform. We're still going to give you a 12-month year for the rate, but instead of it starting January 1st, ending January 1st, it's going to start December 1st and end December 1st in 2014. Now, the question she had was, should you get services before December 1st if you've already accumulated your deductible? That's an excellent question. Your deductible is still going to run on a calendar year basis. So anything that you've met prior to the end of November will continue to satisfy the deductible through December. We're not changing the benefit year. Your benefit year is still going to be January 1 to January 1, but the contract year is just going to begin anew with new rates on 12/1. So you're not going to lose anything in deductible accumulation. That's an excellent question too. The lady was asking about all the options that we have. We have so many different plans available through the SCDA. An employer can decide that they're going to offer one plan and make that available to all their employees. Or what a lot of dental practices have done, they've just said, here's the gamut of offerings that you have through the SCTA, You take a look and you choose the one you want, and we'll pay our contribution based on that one. But if an employer chooses like the HSA plan and makes an employer contribution to the HSA, they can direct one plan available for their employees, or from the practice's standpoint, they can avail all the plans. But it's really at the practice level's decision, not at the employee level. So if the employer can decide whether or not they want to offer multiple plans or just one. The lady was asking if the plans effective December 1st of 2014 were going to be essentially the exchange products. They're going to be, they're going to have to meet the metallic standards, but they are going to have out-of-network benefits, and they're going to have the full Blue Cross network that you enjoy now. So in that way, they're going to be different than the exchange plans. We are going to have to comply with the rating, and we are going to have to meet the metal standards, but your plans are still going to be richer than what individuals will buy on the exchange. Excellent question. The lady was asking about the 5% differential to be able to maintain your grandfathering. What the feds have dictated to retain grandfathering is if I contributed 75% in 2010, if I contributed 75% that year, the most I could lower my contribution by, even to present, is 70. If I've fallen, March 23rd, 2010 is always going to be the benchmark year. So if you were contributing 75% then, however far forward we go into grandfathering, you can never go below 70. So it's not like 5% each year where it can compound. And it's not based on a percentage off the premium, it's based on the percentage that you started at your contribution. So, 5% of 75 is different than 5% of 100, right? So it's the 5%, it's the flat amount. Yes, sir?
Could you speak to the provision that all children who are going to be covered will have dental insurance? Do you know what those plans are going to look like?
I'm surprised that didn't come up earlier. That's a great question. From what I understand, it's essentially it's a medical benefit. It's not even a dental benefit. It's a fluoride treatment. I mean, that's basically the extent of the preventive dental that they're giving the children under PPACA. So it's not much.
So they won't have dental insurance. They will have that provision through their medical provision.
Right. But it sounds good to say they've got dental coverage now. Yeah. The lady was asking how increasing contributions might affect grandfathering. They don't mind if you improve the contribution. If you better the employee, that's fine. It's only going the other way that they're concerned about. Yeah, that's a great question. The lady was asking about an employee 65 years old who's eligible now for Medicare. We have a provision in the Dental Association program, and again, I'll credit Mark and Phil for negotiating this. When a person turns 65, they're eligible for Medicare. I can see that we've got a lot of young people in the room, so you're probably not familiar with this, but when you turn 65, all you get is Medicare Part A. That's all you get. So the government gives you Part A, which is hospitalization. You have to elect Part B, which is the physician and professional care. If you choose to buy the bad drug coverage, you can get Medicare Part D. And then you can go out on the private market and you can buy a supplement that'll cover your deductible and co-insurance on all of that. Okay? So if your employee goes out and buys Medicare Part B, they qualify for a substantially reduced premium going forward through the Dental Association for an employee premium. But they have to have Medicare Part A and Part B, and as long as they're an active employee, you have to continue to extend coverage to them. You can't treat them any differently, otherwise it would be age discrimination. But as long as they buy Medicare Part B, the single premium for that individual drops by like 50%. So it's pretty substantial, but they do have to buy Part B. They have to have the doctor's coverage.
And if they don't?
Well, then they would continue to pay the full premium, the full 65 plus premium. Excellent question. The gentleman was asking about where we are 3 to 5 years down the road. Do we continue an association-sponsored medical plan, or is everybody at that point in the government roles? Blue Cross and Blue Shield believes that there's always going to be a market for us, and that our plans, for the fact that we do have the out-of-network care, we have the broader networks, our plans are going to be better indefinitely for employers than the exchange coverage that they might find. The large group markets aren't even considering terminating their plans and going to the exchanges. Almost universally, they're looking at continuing to offer medical plans. So an awful lot of what we have is sustained by larger employers, BMW, Michelin, bigger employers around the state. So we firmly believe that we're going to have the structure and the membership to continue to support our plans. And I'll share this with you. Yesterday, my vice president met with the president of the company to talk about the future of the associations going forward. Because, again, we're in for some dramatic changes. And they agree that they want to continue to operate in the association market. So I was very encouraged. I got that news late yesterday. So I can see that for the foreseeable future, we'll have a plan that's available to the membership here. Okay, the gentleman was asking about 2 to 50 employees dropping coverage. I think as long as they're with an employer that sponsors the cost of medical care, they're going to find themselves better off financially and better off from a benefit perspective with the employer-sponsored plan than they would on the exchange. As long as the employer offers an affordable cost of coverage and a minimum value standard, that employee can't go to the exchange and buy a subsidized plan. And I want to stress that. The real benefit for the employee going to the exchange is if they get a significant subsidy to offset their cost. And it's going to have to be a pretty significant subsidy to offset the 50% the employer would be paying on the employer-sponsored plan. So I think if the employee really puts the pencil to it, and then if they weigh the qualitative things like we were talking about, no out-of-network benefits, more limited network, I think an informed employee is probably going to make the decision to stay with the employer plan, especially since they're not eligible for exchange coverage as long as you're offering affordability and minimum value. Because then they'd be paying full boat on the exchange. The lady was asking if she pays a flat amount per employee. If you have an employee that jumps class and now the 50% that you were paying has gone up dramatically above the rest of the folks out there that you were paying the flat amount for, and you have to boost that one up to continue to make the 50% contribution. What I would suggest is, instead of going flat amount, go to a percentage of premium, where if you just say, I'm going to pay 50% of whatever it is, and then when they make their elections at the end of the year for the year coming, just index that off their deductions. I think that would probably be the easier way to do it, because if you do end up paying more for one person based on a flat amount, it will appear to the other employees that you're discriminating in that employee's favor. So it's probably easier to go with a flat percentage than a flat dollar. The lady was asking about a medical reimbursement account for employees that have expenses that aren't covered by the medical plan. I would defer that to your accountant. Okay. Yeah. But the FSA plan is limited to $2,500 now. Does anybody here have an FSA plan for yourselves or your employees? Okay. David? Yeah. Okay, the gentleman was asking about the Medicare provision for the people that are actively at work and over Medicare age. And what we allow is, if that employee has to continue to be offered benefits on your plan. You can't say that once you attain age 65, you're no longer eligible for the plan. As long as they're actively at work and they meet the same criteria as every other employee, they have to be extended benefits. But if that employee chooses to buy Medicare Part B, we'll drop the cost of single coverage on that individual by about 50%. And if they have employee spouse coverage, let's say the cost for the individual was $500 and the cost for the spouse was $500 as well. We drop the cost for the individual to $250. The cost for the spouse would remain the $500, assuming they're not Medicare age, and the total premium would drop from $1,000 to $750. So we will reduce the cost of the premium for the individual that turned 65 by 50%. Medicare is very poor about covering prescriptions. Even if you buy Medicare Part D, it's very expensive and it's not very comprehensive. So if they're with your plan, and assuming that, gosh, I know how many maintenance prescriptions I take. A person 65, on average, takes an awful lot of maintenance prescriptions. They would probably realize the savings off the drug portion of your coverage by using this, as you said, like a supplement. Because more than supplements, it's completely covering the cost of prescriptions.
Because they're required to take A anyway, right?
Well, I don't know that it's necessarily required, it's just it costs you nothing. So once you turn 65, you're automatically enrolled in Part A, but you have to enroll specifically in Medicare Part B and Medicare Part D. And there is a premium associated with those two. Any other questions? Yes, ma'am.
Going back to the fluoride being covered.
Yes.
That means that we're now going to have to file that one code with the health insurance?
You know, actually, in application, they're thinking that the MD, the pediatrician, is probably going to give them the fluoride.
And so then what happens when the dentist gets the fluoride and it's going to be denied because?
Well, if the person didn't have dental coverage, would it even be worth filing that one portion of the claim, or would you rather bundle it up and bill the patient? Probably be better just to do it that way, right? Yeah, yeah. So that would be my anticipation, is that I would do it in the global billing for whatever the care was and not have to file that. Good question. The gentleman was asking about one employee covered under the program, or no employees other than the dentist.
Yes.
Well, if you're not in that grandfather class that began July 1st of 2004, we have to have at least 2 people covered for it to be a group. And we have to have 50% of the full-time or the eligible employees covered. So those are the 2 standards that we have.
2 people be my wife and I?
No, 2 employees.
2 employees.
Yeah, because again, state law says that if it's just an individual, you can't really be on a group plan. You have to be on an individual program. And now, if the wife's an employee and it shows up on the W-2
Bingo.
or on your reporting,
Yeah.
then we can do it that way.
You think that's not 50%?
Well, in this situation, I think he's got 1 other employee, so 2 out of 3.
If she leaves, that other employee leaves.
Well, then we'd have 2 out of 2. So we'd have 100%, we'd have 2 employees.
Now, he's got like 5 employees or 6 employees.
Oh, okay, I'm gonna write that down. I'm gonna send you something. Yes, sir.
Hypothetical.
Well, the gentleman was asking about this gentleman's contribution toward the cost of coverage for that employee going to the exchange, whatever. If you want to retain the SCDA plan, we still have to have the contribution made if the employee elects the coverage, and we still have to have 50% of the eligible employees covered. So therein lies the dilemma. If that one employee leaves and we're down to a 1-person group, even though that's 50% of the total employees that are there, we don't have a group anymore because we only have 1 individual. The gentleman was asking, is this gentleman obligated to give the employee money to buy coverage outside the employer-sponsored plan that he offers? Absolutely not. I'll go back to that slide that I had. If you're a 2 to 50 employer, you have no obligation to extend coverage to anybody. There's no employer mandate. There's nothing in PPACA that requires you to sponsor a medical plan. And even pre-PPACA, there was nothing in there that required you as an employer to sponsor a medical plan. The lady was asking about premium calculation and whether or not there was any history of a specific individual weighing in toward their cost of coverage. There is not. Going forward, if I'm a 55-year-old male and I've drummed up millions of dollars in claims costs, and there's another 55-year-old male out there that's running marathons and never had the first claim, he and I are going to pay the same premium as long as we're covered indefinitely. The gentleman was asking, if somebody declines your coverage, are they not eligible for any subsidies under the exchanges? If you're offering a plan that the government deems meets minimum value standards and it doesn't cost your employee more than 9.5% of their annual W-2 wages, then you're offering a plan that meets minimum value standards and is deemed affordable. And that employee, if they go to the exchange, they can still buy coverage on the exchange, but they won't get any subsidy. Or excuse me, no, they can't buy coverage on the exchange and they can't get a subsidy. So the government says that you're doing everything you can. That employee should be in your coverage, not in the exchange. Well, it depends. If the employer sponsors a pre-tax premium payment program, you can take the money out of the top line for the cost of premium, and then they'll be taxed on the balance. So they're basically paying their premium with pre-tax dollars, but the employer has to sponsor that. The deduction for medical expenses, you have to spend like 7.5% of your earnings on medical expenses to realize a deduction. That's what the threshold is. So it's doubtful that an employee just paying premium that didn't have significant out-of-pocket expenses as well would ever realize any benefit in filing for it on their tax returns. Well, the premiums are going to be based on what the benefits are, and I don't know that the metallic plans are necessarily going to, it would depend on really how the benefits weigh against the benefits you're in now, and then we look at the premiums that you're paying versus what they'd be on the metallic plans to really judge how you'd stack up between those plans and your current plans. But the 60% is really predicated off what the plan is expected to pay on behalf of the average cost of a member. So again, going back to the example I used earlier, a bronze plan is expected to pay 60%. If the average cost of claims for a South Carolinian is $6,000 a year, the bronze plan would have to be designed in a way that it would pay $3,600 of that $6,000. Okay? So the employee liability on that $6,000 couldn't exceed $2,400. And that's where our actuaries with their pointy hats and wands go in and say, okay, the deductible has to be this, coinsurance has to be that, so the employee doesn't pay more than $2,400 of the expected $6,000 in medical claim costs. The silver plan, it has to be 70% that the plan has to pay. Gold is 80, platinum is 90. So going back to what we discussed earlier, our bronze plan on the exchange and our bronze plans that we're going to roll out for your anniversary date on 12/1/14 are going to look dramatically different than our competitors. We can have 6 different plans that might meet bronze standard because we've changed deductibles and coinsurance in a way that it all still equals out to $3,600 paid on the $6,000 expected. It's a good question. The gentleman was asking if, based on what we currently consider a family contract is an employee, a spouse, and any number of children. It could be 1 or it could be 20, and you still pay the same premium, you still pay the same family premium. Well, going forward, they're going to assess a premium on each individual, I think limited to 5. I believe they're limiting it to 5 individuals within a family. So I think every adult member is going to be given their own premium. Because dependent children now are covered at age 26, they could potentially get adult premiums. So I think the adult children are going to be off the equation, but there's only so many minor children that they'll charge you for within a family contract. But I'll have to get more information about that. The lady was asking about one individual that maybe drove the premiums for the practice. Yeah, going forward, every practice of the same characteristics is going to have the same premium, whether they had a catastrophic claimant or whether they didn't. So it all depends on how the premiums are inflated for the adverse selection going forward. I really don't want to say that you're necessarily going to get a premium decrease, but I will tell you that that practice no longer is going to be rated any differently than a healthy practice with the same age groups. You know, it was interesting. I was telling Mark earlier, I don't know that I've ever made a presentation which, with as much advanced education as what I've got in this room here. This is it's really daunting, and the questions you've asked have been fabulous. If you have any more, please send them to Mark, and Mark will get them to me, and I'll get you an answer as soon as we can. And I'll be happy to help. Thank you for your time.